Afternoon.
Hey, Dr. Martis. Dr. Kasim has, I don't know if you're going to be able to stay on the call for the whole time or not, but Dr. Kasim has offered to be the moderator, and we
That's
just got some
perfect.
presenters set up, so we should be ready to go right now.
That's great. Yeah. Dr. Kassim is a veteran here in this meeting. He can moderate
Okay,
and he
so
can manage us. So, good afternoon, everybody. Welcome to International Telegram Rounds. This meeting is sponsored by the Pan American Society. Today, I'm going to have Dr. Kassim moderating the meeting. And I'm going to ask Dr. Kassim to please introduce the presenter today.
Good morning, everybody. Today we have the pleasure of hearing from Dr. Padovez. He's a general surgery resident at the University of São Paulo, and he's coming to us.
Kevin, are you hearing me?
He's coming to us from São Paulo, and he's going to tell us all about going.
Are you hearing anything from me?
Yes, we hear you. Can you hear us?
We can hear you. Would you like to load your presentation on the screen?
Okay, fine.
Got it. Oh, went away.
Okay, are you seeing the presentation?
No, now I can.
Are you seeing it?
Yes, we are.
No. Now you can?
Yes.
Okay. Sorry for the Okay, so I'm Jonathan. I'm a second-year resident in general surgery here at the Clinics Hospital of the University of São Paulo. And today I'm going to present a trauma case which we attend here at our service. The title is Going Under the Truck. So we have a previously healthy 20 years old male which came from air medical transport to our service. So the mechanism is not entirely described, but we assume that the patient was driving the motorcycle when he was hit by the truck, then he fell, and then the truck ran over him. At the scene, it seems like he had abrasion on the chest and anterior abdomen, lacerated contusion of the right first digit, facial edema, and bilateral conjunctival hemorrhage. He scored 13 at the Glasgow Coma scale at the scene. His heart rate was of 108 BPM and his BP of 80/40. At the scene, he was put on cervical collar, a blackboard. The pre-hospital care decided to do endotracheal intubation since it was a high-impact trauma and the patient needed air medical transport. So they performed the endotracheal intubation and they started on tranexamic acid. Here is the primary assessment. As I mentioned, we have the pre-hospital data. The collision was at a high-speed venue, estimated of 60 kilometers per hour or 37 mph. The time of pre-hospital care was of 40 minutes. And at the pre-hospital care, they also administered 500 ml of sodium chloride. So since after the patient arrived at our trauma room, we performed as a trauma team a primary assessment following the ATLS. So he was intubated. There was the oral tracheal tube performed during the pre-hospital care. His respiratory rate was of 20 RPM. He was saturating SpO2 90-80%, and there were bilateral vesicular breath sounds present. However, with decreased breath sounds in the left hemothorax, and he also had abrasions at the left hemothorax. The circulation, he was at first hemodynamically stable. His heart rate was of 143, the BP of 12/7. There is, as I mentioned, there were abrasions on the abdomen. He had a stable pelvis and good peripheral perfusion. And since we have the gadget, we performed an EFAST in our trauma room, which was negative. He was, of course...
Jonathan, can you stop there for a minute?
Yes, of course.
Thank you. So can we open this up for discussion? Early management of presumed injury to a patient who was run over by truck. So, Dr. Untrak,
Yes,
could you tell us what you think when you see a patient in the emergency room with alleged injury to the chest and abdomen, possibly some aberration, and there's talk of truck may have run over him? What are the things that we are looking for?
okay, well, in this case, in the field, if he was hypotensive with a systolic pressure of 80 and tachycardic, and he was awake, breathing normally, Glasgow coma scale of 13, this is a case where CAB would be appropriate instead of ABC, based on all the studies Dr. Parada and her colleagues. So in this case, there's a lot of evidence for the benefit of pre-hospital transfusion, and I think that would have been preferable here. And then, but he was intubated in the field, and he did well with that. And then he arrived even more tachycardic. Blood pressure is 120, so he is in stage 1 or stage 2 shock. Even though he Glasgow coma scale is 3 and he's intubated. So in this case, he needs to get blood transfusion, and I would repeat the EFAST because he must be bleeding somewhere. And the evidence suggests perhaps into the chest, perhaps ruptured spleen, but with all the contusions on the left side. And so you need to determine the source of the bleeding. Also, the right, I said the right thigh, there were lacerations, is that right? So you need to rule out a fracture of the femur. So in this case, he needs 2 IVs, call for some blood. If you have whole blood, that would be preferable, or a massive transfusion protocol based on his pulse. And I would get I'd repeat the EFAST, get a chest x-ray and an x-ray of the pelvis and femurs bilaterally.
Thank you, Dr. Untrak. Dr. Suprat, would you like to add any further pearls to this?
I agree with resuscitating this patient, and although FAST is negative, he may still have significant bleeding in the abdomen and the pelvis, given the mechanism. So I think I would start with resuscitation and blood transfusion for this patient. And the blood pressure is okay, but he was very tachycardic, so he's not very stable. If I can bring his heart rate down, I think I would send him to the CT scan and see the bleeding source in the pelvis and the abdomen. And I forgot to put in the chest tube to the left hemithorax because he had decreased breath sound, and he may have a bleeding in the pneumothorax in the left chest. Thank you.
Dr. Silva, would you like to contribute? Dr. Silva, can you hear me? Okay, so we'll carry on. One of the things that I was impressed with in the presentation of this case initially was there are some physical findings that was quite remarkable and pertinent to this type of injury, such as aberration on the skin, perhaps some tire marks, and also swollen face and conjunctival hemorrhage area. Those are all some of the clues that we look for in patients with this type of injury. Jonathan, would you like to carry on?
Yes, I would. I'm sorry, but there was another issue with my computer. I'm very sorry about that. I'm just trying to fix it,
Okay.
and I will move forward.
Dr. Kassim, I think Dr. Calderon can comment as well. Dr. Epstein can comment as well. And maybe Dr. Kobe from Japan. And all this,
Oh,
you can put your video on as well, please.
okay.
Super as well. Dr. Zapata also, Calderon Zapata always has a good comment as well, please.
Yes, good morning again. Thank you for the opportunity.
Oh,
Yes,
good.
I was taking a close attention to this case and it scares me. I guess this patient is under sedation for the intubation, and that scares me because it's not only the sedation that could decrease the blood pressure. The patient can crash, can arrest only because of the intubation. So both Dr. Untrak and Dr. Supa are far wiser than me, but it's really important to have in mind that circulation is more important than the airway if the airway is not immediately threatened. If it's not, it is better to resuscitate the patient with blood, whole blood if you have. I don't have, I only have components, but that's more important than before intubating the patient. Sometimes when the patient shows up in the emergency room in shock, I tell the ER physician, just hold on the intubations until the patient is in OR, but please help me out with that resuscitation. Yes. Well, now we have physical signs of injuries in both the chest and the abdomen, but even with the FAST is negative, I must just suspect that maybe the bleeding could be on the chest and on the abdomen. So I can just keep on going with the resuscitation and repeat later the FAST, or just bring the portable X-ray to have images of the chest and the pelvis just to see if there is any injury in the or maybe at the X-ray of the right hand, because maybe there might be an injury there. And well, and let's see if the patient responds with a resuscitation, because he's not stable. He's very tachycardic. Yes, I would like to know how much fluids he received, because he was hypotensive in the field, and he now has at least a normal blood pressure. Well, and let's see if the patient is, it will be better if the patient gets more stable. He can be taken to the CT scan to try to look for any injuries in the body and in the brain. But okay, that's all I have by now. Oh, okay. It's always important to complete the primary survey as complementary to the primary survey, to place the nasogastric tube, just to see if there is some blood in there. The urinary catheter, also to see there is blood in the urine. And the ABG, the base deficit, gives a lot of information about how much blood product that the patient needs. Thank you.
Dr. Kobe, would you like to chime in?
Thank you. So I'm in Japan. It is midnight, so I must little bit sleepy. So just because I'm a bit off. So I think if first is negative, but the patient has something, a lot of bleeding inside his body. So I think we should search what region is bleeding. It is the most important thing. Thank you.
Okay, so are you hearing me now? I'm trying to connect to my presentation again. I'm now connecting through my phone. I'm trying to be able to share my screen.
Go ahead, Jonathan.
Just a moment. I'm sorry about all of that.
Anybody else wants to say anything while we are waiting for Jonathan to reconnect?
While we're waiting, could I suggest if Dr. Padovez cannot share a screen, perhaps he can point his phone's camera at his computer screen, and then we'll be able to see the presentation.
Great idea.
Okay, this is a way we can try. Just a moment. Let me see.
There we go.
Okay. Okay. So are we seeing the presentation? Okay, great. Are you hearing me?
Yes, we are. Go ahead.
So moving forward, we have GC Glasgow Com score of 3T, and there is PPROs equals round and reactive to light, and the exposure we have already mentioned. Yes, as we were saying, he presented some signs of a high impact trauma, and these abrasions added with the subconjunctival bilateral hemorrhage suggest that he probably had a high pressure diaphragm lesion. So at our trauma room, we performed some auxiliary measures. As we mentioned, we performed the EFAST, which was negative. We also did a whole body CT scan, which I'm going to talk a little later. And we also started some of our institutional protocols. We assessed the patient in our go timing, which is under 30 minutes. We assessed the patient with the trauma team. We also administered the tetanus vaccination, and we transported the patient with safety packing. You were asking about the fluid resuscitation, and I agree that there might be points of that we could have done it differently, but till now he received in the pre-hospital care 500 milliliters of chloride sodium, and here he received 500 mL of lactate ringer. He at this point had not received any kind of blood component. He was also sedated with propofol and fentanyl. May I move forward?
Yes, go ahead.
Okay, so at the admission, we have these arterial blood gas analysis. We are able to see that the pH was of 7.29, the base excess was minus 60.6, and the lactate was of 30 milligrams per deciliter. So we performed—
Is that normal for your hospital, the lactate being that high?
I mean, we since we are a reference center here in São Paulo, we do receive very severe patients. So this is not uncommon for our patients to arrive with this lactate. Something that I may point out is that he had an hemoglobin of 10.1, and this is not very common since it's just later on that we usually see the hemoglobin lowering in trauma cases.
Would you transfuse a patient with a hemoglobin of 10 at your hospital?
Here we usually start our protocol of transfusion based not only in the laboratory parameters, but of course with the clinical state of the patient. With a base excess of -6, at some other reference with -8, we can already start hemotransfusion. This was not the case in this particularly patient, but as I was mentioning, there are some points that we could have done it differently now in a retrospective view.
Dr. Untrag, would you like to comment on these?
Well, the lactate, what's the upper limit of normal at your hospital for lactate?
It's around 19.
How much?
19.
19, so it's elevated mildly. Well, as Dr. Padovez said, clinically, he was run over by a truck, is tachycardic and hypotensive, and I wouldn't wait for the blood test to come back. I wouldn't worry about that. I would just proceed in resuscitation before, while you're putting the IVs in, you can draw blood and send it off, but that's secondary. He's hypotensive, he's tachycardic, was hypotensive initially, serious trauma. So you need to figure out also someone who's tachycardic and hypotensive, we wouldn't take them straight away to the CT scan being unstable, but if it works in your facility, and apparently it did, that's okay. If not for the CT, repeat the EFAST and then the chest x-ray, and then a film of the pelvis and both femurs, which you can do at the bedside. But I wouldn't withhold blood, because you get this, he received only 500 cc's of Ringer's lactate, so he's not yet hemodiluted. If he were to get more fluid or later down the line, he'd get more hypotensive, and he needs blood and not crystalloid.
Excellent. Dr. Supra, would you like to contribute?
I agree with early blood transfusion in this patient. Thank you.
Jonathan, carry on.
Okay, so it's important to highlight that in our hospital, just a minute. In our hospital, the CT scan is just in front of our trauma room, so we very oftenly are very able to do it under very short time periods. It's very quickly. We have some protocols about it. And the patient at this point was still hemodynamically stable, and the time from the hospital admission to the CT scan was of 11 minutes. Here I present the pre-CT. We are able to see that there is kind of a disruption in the continuity of the diaphragm in the lower left hemothorax, but there is very little information only with the pre-CT. So I'm gonna show you the short video of the CT scan.
Qual que é a solicitar acesso aí? Puta merda, eu compartilhei aqui.
I'm sorry, again, there is this issue with...
Aqui, ó. Gerenciar acesso. Gmail, coloquei seu nome.
Maybe if you want to add something before I show the video. Okay, I'm sorry again. No, not that. Maybe I can show it with my camera. So here we have, I'm sorry. Okay, so I'm sorry about this. So again, here we have the CT. We are able to see that there is a traumatic diaphragmatic hernia. There is the stomach, the spleen, the transverse colon, and some loops of the small bowel. I'm gonna show you one more time the video so you are able to see it. Okay. So we performed the CT of the chest and abdomen, so the whole body CT, and we find the traumatic diaphragmatic hernia. with herniation of the stomach, the tail of the pancreas, the transverse colon, the descending colon, loops of the small intestine, and there is the restricted atelectasis of the left lower lobe. We also find hemoperitoneum, and there was also a pelvic fracture. So here at the end of the secondary assessment, we have the diagnosis of a blunt abdominal and thoracic trauma. We have left traumatic diaphragmatic hernia and a pelvic fracture. And the patient then developed, he started to be hemodynamically unstable, requiring vasoactive drug. We had to start norepinephrine, and then, well, I mean, I don't know if you wanna.
Can you stop? Can you stop there,
Yeah, I can.
Dr. Untrak? Would you
Well,
like?
how about let's Dr. Supa first this time. How's that? Or Dr. Calderon, one of the others, and then I'll comment.
Okay, Dr. Calderon, would you like to chime in?
Sure. Well, I couldn't understand. I was trying to look better at the CT scan. I could see the traumatic diaphragmatic hernia, but I was unable to see there was any free fluid in the chest of the abdomen. I was unable to do so because I'm trying to figure it out, where is he bleeding from. I didn't know if there is any other chest injury like a chest contusion or pulmonary contusion or hemothorax.
There was none.
No. Okay. I'm still trying to know if there is any bleeding, because maybe we can place the chest tube in the left chest. If the patient doesn't recover the hemodynamics, take the patient to the operating room, not only to repair the diaphragmatic hernia, just to look if there is any other source of bleeding in the. Oh, I can see the CT scan better.
Sorry, I'm
I don't
sorry.
see. Yes, that's fine. Sometimes it happens. And I'm still trying to know, do you say he has a pelvic fracture?
Yes, but there were no active bleeding in the pelvis, and since and I mean I'm not going to give spoilers about the treatment, but there were no bleeding from the pelvis.
Okay, so it's bleeding somewhere. Well, somebody asked about if there are any femur fractures. I guess it's negative, right?
There is no femur fracture.
Well, he must be bleeding somewhere. So,
Dr.
so
Calderon, I have
yes.
a question for you. You said that you will put in a chest tube on the left side. Did you say that? Could you please tell us how exactly you would do that?
Sorry, I don't understand well the question.
I would like to know exactly how you would accomplish putting a chest tube on the left side, knowing that you have a diaphragmatic hernia.
That's
the
a tricky
mechanism, exactly how you do it.
No, I wouldn't change any technique. I mean, I'm trying. I know I will be trying to avoid doing
chest
any damage to the any bowel inside the chest. Maybe we can do it in the operating room. I guess if in that, let's explore the patient. I guess just to say if there is any bleeding. Maybe reduce the hernia in OR and take a second look inside the OR. Let's see, through the diaphragm.
Okay.
And place the chest.
I misunderstood you. I apologize.
No, actually, that's right. Actually, you're correcting me, because I was thinking about placing the chest tubes directly in the emergency room. That would be maybe a big mistake. Maybe. Well, but if the patient is still hypotensive, I would explore the patient in OR just to double check if there is any bleeding or any bowel injury besides the diaphragmatic hernia.
Dr. Supra? Dr. Supra, would you like to tell us your management?
Yeah, in this case, I think that putting in the left chest tube in the ER is not the mistake, even though he has the diaphragmatic hernia. We can still use a standard landmark for a chest tube insertion and do it gently. You can use the blunt clamp like Kelly to enter the pleural cavity, and I always use my finger to do the finger thoracotomy to explore the pleural cavity first, to feel for the lungs or the visceral organ in the left chest before I put in the left chest tube. So I think if you use a standard landmark and put it in with gentle and care, it would be okay. Even though the patient has left diaphragmatic hernia.
And
And
which
once
intercostal
again,
space would you use?
pardon?
Which intercostal space would you use?
If I know beforehand that I have the diaphragmatic hernia, I may go a little bit higher, maybe the fourth. But I think that the fifth is still okay. If you do it gently, if you do it with caution. And for the further management of this patient, I'll take him to the OR immediately to do the exploratory laparotomy. He must be bleeding in the abdomen or in the left chest. So given that the patient is crashing just after the CT scan, I think he needs small chest tube at this moment, because he may bleed further into the left chest and causing like a compression of the mediastinum or the lungs. So I think putting in the left chest tube in this patient is beneficial. Thank you.
And Dr. Supra, what type of position you would have this patient in the operating room?
I think supine position is the best for him because he's not hemodynamically stable. And second thing, we need to thoroughly explore the abdomen. So I think the supine position will be the best position for him. And even though you may have to enter to the left chest, we can still do a left anterolateral incision, or even the thoraco-abdominal incision to the left chest. I think supine is okay. You may have you may put some cushion under the left side of the body and tilt the bed to get the better exposure to the left chest. But supine is, I think, the position of choice in this patient. Thank you.
Thank you, Doctor. Dr. Untrak?
Yes, I agree with everything Dr. Supa just said, although in this case, I probably wouldn't put the chest tube in based on the CT scan. I agree you can place a chest tube carefully, finger exploration, but the problem seems to be he needs exploration of the abdomen. The other thing is he's been here now over an hour, and as far as I can tell, he hasn't yet gotten a single red cell transfusion. I think this, more than the epinephrine, this patient needs blood. I mean, as a young guy who's tachycardic, now hypotensive at 20 years old, I would just give him whole blood preferably, or 1 to 1 to 1. He needs that more than epinephrine, and then straight to the OR for a laparotomy. There's blood in the subhepatic space. He's got all of his viscera up in the chest, so a midline laparotomy. Reduce the viscera, and then you'll see right away if he's bleeding into the chest. And then the chest tube I would put in the OR, probably at the end of the case. But he needs to be in the OR, blood and in the OR.
Dr. Kobe, would you like to add?
No, thank you.
Okay, short. Jonathan, go ahead.
Okay, are you still seeing my presentation?
Nope.
No.
We see
Okay,
you.
so I'll try to present again. I'm sorry, for some reason today we are having a very hard time with our internet. I'm sorry about that. So, yeah, I think that there is. Okay. Are you seeing the presentation?
Yeah.
Yes.
Okay, so let's move forward. So then we decided, since the patient was progressing with hypertension and need for vasoactive medication, we moved forward, leading the patient to the OR. The time from the hospital admission to the operating room was of 2 hours and 30 minutes. So here I'm going to present the major findings of our surgery, of our intraoperatorial view. So here we are able to see that there is a large detachment of the subcutaneous tissue and the aponeurosis, which highlights the possible mechanism of attraction when the patient was under the truck. Okay, so this is what you can see now, and then we are showing the are you hearing me? Okay, so here we have zone 2 retroperitoneal hematoma, which we did not explore since there was no sign of active bleeding and there was no extension. Here we are reducing the abdomen visceral from the thorax to the abdomen, and we are able to see the diaphragmatic traumatic hernia. And there is, of course, some hemothorax, some hemoperitoneal, but there were no sign of active bleeding. There is a major tear in the diaphragm, which starts from the right coronary ligament of the liver and extends to the chest wall and the 7th intercostal space. Here are some pictures of our major findings. Again, the detachment of the skin and subcutaneous tissue, suggesting what we assume would be a very high impact traction mechanism. And there were also some bruises in the mesenteric of the small bowel intestine, but there were no signs of active bleeding and no signs of bowel injury, no ischemic injuries at all the intestine. Here, do you want me to move forward, or maybe do you want to do some comments at this point?
Keep moving forward, please.
Okay. So again, we are able to see the tear in the diaphragm, which extends, as I mentioned, from the right coronary ligament of the liver to the 7th intercostal space. And we hold it here, showing all of the lesion. A major and important information is that the diaphragm were not detached from the chest wall. There were just this major tear.
Okay, can you stop there now?
Okay,
We'll come back to you to see how you repaired this.
Okay.
Dr. Super, what you're seeing, and could you comment to what your management would have been, or any different?
Thank you, Dr. Kasim. For this patient, I think number one, the laparotomy incision is a little bit too small for me.
Right.
I would try to extend it above and below the lower limits and upper limit of your incision to check the whole abdomen thoroughly. And I think extended it to the side foil would help with the repair and assessment of the left chest. And second thing, if you can grab the edges of the diaphragmatic tear and there's no tension, I think we can do the primary repair of the diaphragm. I usually do it with interrupted proline or nylon suturing and put the left chest tube properly. You may also examine the left chest through this hole to make sure there's no active bleeding or injury to the left lung, the left chest wall, and the heart and mediastinum too. And After checking the abdomen thoroughly for injury or bleeding, we can close abdomen in this patient. But as we can see that he has internal degloving of the abdominal wall, so we should not do the skin closure in this patient. We should irrigate and clean the subcutaneous flap nicely, and then leave the skin open. And then you move him to the ICU and check for the abdominal skin flap viability closely. Should the skin flap turn necrose, we may have to go back to the OR for debridement of the abdominal wall skin. And that is my management. Thank you.
Excellent pearls. Dr. Calderon, would you like to add?
Well, just a little bit. Well, I'm not going to speak about the incision, but Dr. Supa is right. And I was paying attention that he has friction burns in the abdominal skin. We have to manage it as we have to do a clean out of the skin and handle that like the burns. About the diaphragm, I will also try to approximate. I prefer using silk because it's softer, but a non-absorbable suture or whatever you want to do, but a non-absorbable one or O suture. I will try approximate, but if this is not enough, we may use a mesh. In this case, we can use we have visceral contact mesh, or some time ago we harvested fascia lata just to do as like a mesh in the diaphragm defect. Now I see there is some bowel injury that now don't look ischemic, but I think that it would deserve a second look. I would take a second look, so I would do and even leave the open abdomen with whatever you have, the abdominal bag, and come back a couple of days later just to take a second look to that bowel, just to double check if it's in good condition, just to do the definitive closure of the abdominal wall. That's all I have to. One question, sorry, Jonathan. Did you take a look at the zone 3 of the retroperitoneum?
Jonathan, did you hear the question?
No, I'm sorry, I did not.
Could you repeat that, doctor?
Please?
Yes. Did you took a look at the zone retroperitoneum zone 3? Did you?
There were no hematoma on zone 3. We did explore. I just didn't show you.
Thank you. No more questions.
Well, different way of doing things. That's the best thing about these conferences. We get to hear a different view from different parts of the world. Dr. Untrag, now it's your turn. Tell us what you would do.
Yes. Ditto to everything that Dr. Supa and Dr. Calderon said, although I don't know if I would plan a second look based on the way the bowel looked, but if you're concerned that it may prove ischemic, then certainly. I have two additional points. What was the condition of the patient hemodynamically at this stage, Dr. Jonathan?
Okay, so I was going to mention this after the surgery, but at this point, the patient still did not have received any blood component, since this is, I think, one of the major improvement points of this case. But he was hemodynamically unstable, around 15 ml per hour of norepinephrine, but he was maintaining millimeters of mercury.
I'm sorry, it broke up. What were his hemodynamics?
The macrohemodynamics, he was receiving norepinephrine at a rate of 16 ml per hour, and he was maintaining an AAP of 80 millimeters.
And his pulse?
I beg your pardon?
The pulse rate.
Repeat?
The pulse rate.
Oh, the pulse rate. He was with a high heart rate of around 120 to 130 ppm.
And his urine output?
He ended the surgery and the norepinephrine of 16 ml per hour.
Yes, and his urine output, was he producing urine during the operation?
Oh, okay. So o volume a gente tem. We do not have in the description. I'm sorry about that.
Okay, all right. Anyway, the two additional points, I'm forgetting the second point. The first point was about the degloved skin. I agree with not closing the skin. And another option to consider, if it looks like it's going to be necrotic and you'll have to go back and resect it, there's the option, especially if the patient is relatively stable and you can take a few minutes, I would harvest the degloved skin as a split thickness skin graft, and then you can still leave the donor site present, and then put the skin in some saline in the refrigerator. And if you notice necrosis, then you can go back, excise the donor site with the subcutaneous tissue, and then apply the harvested skin as a skin graft. And you could do that early. That's likely to take very well, but that's one option to consider. Although that's secondary to making sure the patient is hemodynamically stable. If you have to get them out of the OR sooner without doing that, then I would forego harvesting the skin.
Thank you, Dr. Untrak. 3 different ways of managing this case we heard today. Now we'll get back to Jonathan to see what they did. Jonathan, go ahead. Tell us what you did.
Okay, so are you being able to see my presentation?
Yes.
Yes.
So as we mentioned, we performed an infusion of the round ligament of the liver with a small amount of hemoperitoneum. There were some bruises in the mesentery of the small intestine, ascending colon and sigmoid colon, which did not determine any kind of ischemic bowel. We also have the major finding, which was the left diaphragmatic rupture extending from, as I mentioned, the coronary ligament of the liver to its attachment on the thoracic wall without detaching the diaphragm. Here are some pictures that you already saw on the video. So we decided to do a copious lavage of the hemothorax with warm saline. We also performed this in the peritoneal cavity. We did a left thoracostomy under direct visualization, and we decided to repair the diaphragm with a primary suture, a primary repair with PDS suture with a separate suture in 2 layers. Here you can see the tear of the diaphragm, and then the 2 layers and the final aspect of the diaphragm.
What did you use for the first layer?
Both layers we use PDS.
Both layers, okay.
Yes. So with regards to the detachment of the skin and subcutaneous tissue, we decided to deal with that as we would in a major burn trauma. So use silver how do you say it? We silver sulfadiazine, and we perform we treated it as we would in a major burn. We put some drains at the subcutaneous tissue, and we repair it without taking any skin off or doing any excision on the tissues. So, and I am already presuming that there will be some comments, and I agree with this very interesting discussion. At the end, not counting with the 500 mL of RL in the in the trauma room, but he received 3.5 liters of finger lactate, 1 vial of albumin, no hemocomponents at the end of the procedure. Here are the parameters of the patient. He was with a heart rate of 103. He had an BP of 13 over 60. He was with norepinephrine, 16.8 ml per hour, a vasopressin of 9 ml per hour. Those were the respiratory parameters, and I really do not have the information about the urinary catheterization debit at this point.
Jonathan, I have a question. Do you have an aversion to giving blood transfusion to patient who is in hypovolemic shock? Do you have difficulty getting blood?
Answer to that question, but this is very uncommon for management. We are very open with hemocomponents transfusion here in our service. We thought of bringing this case exactly because it kind of but yes, I mean, this is the major improvement situation. Why, after all of this major trauma in a previously healthy male patient that would benefit so much from the hemocomponents, why did we only use crystalloids resuscitation volume that this have intern meetings, and of course,
Jonathan, your audio is really bad. Is there a way for you
question in
to?
this specific case, emergency department, and also the. Okay, I'm gonna try to improve it somehow. Talvez fosse ligar o seu e eu desligar o meu. So, okay, again, we have our quality intern meetings, and we raise this question about in this specific
we can't understand you again,
case,
Jonathan.
us in the general anesthesiologist. Oh, okay, I'm sorry. I'll try to fix. Eles não estão conseguindo me entender, eu preciso de outro áudio. Mandar no seu, Flávio? É, tá alto.
It starts off fine, and then we can't.
Jonathan, we are having little difficulty with the audio, so we will stop at this moment and we will go around and ask the panelists what they thought about it. And perhaps you have a different way of managing this than the usual way that you have done in the past. And there might be some circumstances that made it necessary for you to do this way. But all in all, giving ringer lactate for a patient who is in traumatic hypovolemic shock, it is not considered the norm in many places. But be that may, it is getting late. We got 3 more minutes left. Dr. Untrag, will you summation, please?
Yes. So it looks like you this poor kid was run over on a motorcycle, run over by a truck, and it looks like you saved his life, despite mistakes that you admitted. So you shouldn't give more than 1 liter of ringers. You did give him the tranexamic acid. I would have started blood early, but I'd be interested to know what his hematocrit was after you got him off pressors and have his urine output brisk, and what were his hemodynamic parameters at that point? How easily could you get him off pressors? And what was his hematocrit, having received no transfusions? So, but otherwise, despite not being perfect, despite perhaps doing a few things that you would do differently, and you admit that you would do them differently, you saved his life, and you know, no one's perfect. You don't have to be perfect, and you had the proper introspection, and I still applaud you for handling this case, especially as a second-year resident. Well done. Well done.
Dr. Calderon?
Yes, I'm also asking, where is the blood? Too much
Thank you.
crystalloids. You really don't want to risk him with the coagulopathies and abdominal compartment syndrome. And he's on double vasopressor. So when I always tell my anesthesiologist and my IR physician, if the patient is on vasopressors, it's maybe because we are doing something wrong with a resuscitation. Maybe not, definitely. One more question. Did you say there was an involvement of the pancreas? Or maybe... No?
The answer is no.
No, okay, thank you. Okay, thank you. No, I don't have any more comments.
Dr. Supra?
For the surgery, I usually use a non-absorbable suture to repair the diaphragm. I think it's more durable, like nylon or Prolene, as I mentioned before. And for resuscitation, you may give vasopressor to the trauma patient who is in shock and not responding to the bleeding control and blood transfusion and resuscitation. Especially if you have an evidence of vasodilation, like you've been monitoring the systemic vascular resistance. I'm sorry. You have a patient who does not respond to resuscitation, blood transfusion, and evidence of vasopressin. I think it's justified some vasopressor, because trauma patient can have like vasodilatory shock from all the inflammatory cytokines. But like Dr. Untrat and Dr. Kasim mentioned, if you give the vasopressor too early, you may improve the blood pressure by causing vasospasm, but you will not improve the perfusion to the tissue, because the blood will go distally more difficult, because you like compressing the blood vessel, and you may increase end organ ischemia and lactate level. Okay, but you get the better blood pressure, which is not our goal in resuscitation. Thank you very much for presenting the interesting case, and great step for the patient. Thank you.
So finally, being a moderator, I have to add a couple of things. Jonathan, you and your team did very well because you saved the patient's life. That's what matters the most. But one piece of pearl that I would like to throw at you, there is a picture by John Holcomb, spelled Holcomb. He's a trauma surgeon at Houston. And he has two pictures he will show you when you give, what happens to the patient when you give lots of crystalloid. When you take too much, when you are on drugs, your brain swells up. And when you give too much crystalloid, your intestine will swell up. And these two pictures are available for you to see on the internet by John Holcomb. Too much crystal oil is not good. So having said that, you save the patient's life. That's what counts at the end. It was an excellent case, well managed. We learned a lot, especially from the discussion. Dr. Supra was good. Dr. Calderon added a few other things. And of course, Dr. Untrak always gives us things to think about. Thank you and have a good day. Dr. Martos, it's your turn now. Thank you.
Yeah, Dr. Cassim, you did an amazing moderating. Thank you very much, sir. Just some message. Good case, race. Congratulations, Dr. Carlos. Dr. Carlos Menegoso is going to be contacting all of you. He's going to be the one managing the conference. I know for the boy still one, I know Dr. Kobe going to present second week of October. And Dr. Supa, please contact me. You would like to invite you to go to present in November, sir, if you can. Okay? To be the case presenter. And also, please respond to Carlos Menegoso. He's going to try to schedule your presentation throughout the next 6 months, okay? Great case. And looking forward to meeting you all next week. Thank you.
So,
Dr. Menegoso, are you there?
Yes, I am. Sorry about that. I had some troubles with connection. Just made it like 30 minutes ago. I just want to tell everyone that I'm going to put my email on the chat so you can send me messages and we can schedule all the presentations. Thank you.
so just a final comment. I would like to thank you all to listening to this presentation. To say that the patient at the end did very well. He received, he was discharged from the hospital after 2 weeks. We are still following him, and he has no complaints right now. And I'm sorry, I'm deeply sorry about the technical issues that we had on today's meeting, but thank you for all your patience. Have a good afternoon.
Thank you very much. Great case. Thank you. Bye-bye.